I would like to wish you welcome on this session. And I would like to ask you if you could possibly go to take a seat, and then we can start. I first want to introduce Professor Alan Tyndall. He's sitting next to me. He did do a lot of work for the Scleroderma Association, and he is also quite important for the patient group like Vesca, and I think it's very nice to sit next to him, and he will introduce some of the speakers today, and I will make a first start with the introduction of Professor Christopher Denton. He's sitting next to me. You have seen him quite a lot of times in this conference, so I only tell he's from England, and he is quite humble in being not to be meant to overcome too enthusiastic introduction, but I would like to say it's a very great effort to have him here. Thank you.
Yes. Thank you. So thank you very much. I'm not humble. I just always think that it is better to have less of an introduction and to maybe be judged after you've given your presentation rather than be set up for something very special. So I'm going to just give a short presentation to think about what's new in systemic drugs. And I think what is important, and I think you should see this as a themed session, because what I'd like to do is talk about some of the things that are happening or hopefully going to be new developments for options for treatment for systemic sclerosis, and then it can be put into the context of the next talk talking about stem cell transplantation. I think all of these are really exciting treatment options and really show some of the progress that's being made in understanding the disease. Those are my disclosures. So I thought I'd start with a summary slide, just to sort of really state a position statement, if you like. So I think the first thing to consider when we think about systemic drug therapies is that we should always, and I always say this to my patients, regard scleroderma as a treatable disease. It's not a curable disease, but I always explain to patients that most aspects can be treated, some more effectively than others. But we aren't in the era that we were in, even 15 years ago without any therapies. We even have therapies that include scleroderma in their licensed indication, particularly for vascular complications of pulmonary hypertension, of digital ulcers. So this is a time where we've got a new set of struggles sometimes to have licensed therapies and making sure that our patients get access to those therapies. And certainly that's a challenge for us as doctors sometimes, knowing we have treatments that might help patients, letting patients get to them. We also have very robust recommendations and guidelines internationally, nationally, that I think are helping patients and helping doctors to deliver therapy. And we're developing, certainly in the UK healthcare system, pathways to access the different approaches, which includes stem cell transplantation. And Yap and I have worked together when he was working in the UK, developing access to that treatment for appropriate patients. We also know that immunosuppressive therapy, dampening down the overactive immune system of scleroderma, is an effective treatment for some patients and for some complications, but we also know that we need to balance the benefits you get from the risks of the treatment. And I'm going to share with you just a few results from recent clinical trials, not of treatments that are licensed, but sort of perhaps might eventually be licensed for the disease. If we're thinking about systemic drug therapies, I just wanted to reintroduce the idea of targeted therapy, but remind you that targeted therapy means different things to different people. To a clinician, to a doctor looking after scleroderma, targeted therapy really means targeting the appropriate organ. So we might think about a therapy that targets the lung or the heart or the kidney or the skin or the gut in scleroderma, and that therefore a patient with scleroderma might need multiple therapies to target different aspects of the disease. But another way of looking at targeted therapies is thinking about the biology of scleroderma, the process that leads to fibrosis or vascular blood vessel damage, the actual cellular dysfunction, a bit like when in cancer we know that there are fundamental things that have gone wrong with a cancer cell and that's why it becomes a tumor. we think in scleroderma, in one or more cell types, sometimes something could have fundamentally gone wrong, and that could be a very specific target. And I say all of this because when we're thinking about new therapies, one way to develop new therapies is to understand what's gone wrong in the cells or in the disease and to try and logically target that. So this is a busy slide that I've used before, and it is deliberately busy because it's really just taking that concept forward and showing that, in fact, we're way beyond just dreaming about having therapies that target specific processes in scleroderma. We're actually in an era where we've got therapies that are licensed for the vascular complications that target very specific pathways like endothelin, a factor that drives vascular damage, prostacyclin stimulation, which is a factor that normally makes blood vessels healthy. And then you can see, if we move down, and the sort of red means the therapy is already licensed and available, blue means that it's being tried in scleroderma, and you can see that we actually can start to think of dissecting the disease, vascular, blood vessel problems, inflammation or immune dysfunction, and even fibrosis. Fibrosis is the biggest challenge for us because it's the real complication of scleroderma, hardest part to treat. But I just show in green at the bottom, they're not licensed therapies for scleroderma, but they are licensed therapies for fibrosis, both licensed for lung fibrosis, and in fact both being tested in scleroderma to see if they might be useful in the disease as well. So I think at both ends you can see that we can potentially have some new hopes for systemic therapies for our patients. And again, I just highlight exactly the drugs that are being used now in clinical trials. And I just wanted to say, and again, this is quite a busy slide, but it was really to highlight that not only have we got progress in those options for treatment, but we've also become much better at designing clinical trials to test our drugs. And we've learned two things, really, I think, fundamentally from many years of trying to work and improve scleroderma trials. The things that we've learned are relearning old lessons. The first is that you need to do a trial for long enough to see a difference between different treatment options. And the second thing is that you need a control group. Whatever treatment you're doing, however much confidence you have in it, you'll only see whether it works if you compare it to a control group, which might be another treatment, or it might be a placebo, a drug that does nothing at all, so that you can really see whether that is making a difference. And it's by relearning those lessons, I think, we've made progress in trials. So I wanted to run through a few agents, a few drugs that we might think of as new potential systemic treatments or that might be useful. So the first drug is rituximab. So rituximab is an antibody therapy that is in wide use for rheumatoid arthritis and licensed for that and for some other specific diseases. But it does have some potential in scleroderma because scleroderma is associated with too many antibodies and with autoimmune processes, and there is certainly some evidence that rituximab may be helpful in scleroderma. We in the UK are doing a large trial of lung fibrosis called Recital, which is comparing standard treatment with rituximab for lung fibrosis to really understand how useful it is. But there's already a feeling that it's helpful, and indeed we're using it in some of our patients, particularly those with very bad lung fibrosis. And here's an example of one of our patients. You can see the CT scan at the top shows lots of white, which is fibrosis or scar tissue in the lung. This patient had failed to respond to cyclophosphamide and mycophenolate or Cellcept, the standard treatments, and so we didn't feel there were any other options, and so we got funding and gave this patient rituximab treatment. And you can see that the lungs got a lot clearer, and the graph on the right shows how the lung function tests took an upward turn and improved after treatment. And it wasn't the only case. We in fact show 6 cases here that we published to try and provide information for other doctors about the use of rituximab, and other centres have had similar positive experiences. So it's an option for treatment. The exciting thing is it's already available as a licensed therapy, and so it's something that could be considered. We would consider it, but we consider it as a sort of therapy when other therapies have not worked in appropriate patients. Wanted to move to something that was not so, that's a little bit further from being available as a clinic, but something that's very close to my heart as a researcher. So for many years now, I've been interested in the potential for a protein called transforming growth factor beta to be blocked as a treatment in scleroderma. This is a protein that your body makes to make scar tissue, so it's a very good protein if you've cut yourself and you want the wound to heal, but it's not such a good protein if you're getting inappropriate scar formation in the skin or in the lungs in scleroderma. And the reason why I've been very focused on this for many years is because we know that levels of TGF-beta are increased in scleroderma. So it makes sense that you might want to block it. And in fact, just to show you some of the research work that we've done, we were very interested to compare what the difference was between a scleroderma patient when they were at their worst, at a very severe stage in their scleroderma, to what had happened after 2 or 3 years, fortunately, if the patient had improved. And so we did this study, which just compared the differences in gene expression in the skin between patients who had mild scleroderma and those who had severe scleroderma at those 2 different stages. So early stage disease versus late stage scleroderma. And what you can see is at the early stages, you have high levels of all of the genes that are regulated by TGF-beta. All of these are very typical TGF-beta regulated genes. And when the scleroderma improves, the gene levels go down. So that's not proof that that would be a useful thing to do, but it's suggestive. So we tried for using different sort of ways of blocking TGF-beta for a number of years, and I'm very pleased that there has now been a successful trial in terms of blocking TGF-beta, and this was the study that Bob Lafiatis from Boston led. This is not a treatment that's in any way close to being available for patients, but it does provide the next level of proof that this might be a logical thing to do, because what Bob was able to do was to actually use an antibody to block TGF-beta and show that the skin score and the skin biology changed, like I showed in the skin biopsies that from our center, that if you lower the levels of TGF-beta in the skin, you do get some improvement in the features of scleroderma. So this is a first study, and of course that doesn't take account of whether this is a toxic therapy. That would be an important thing to make sure it didn't do bad things. But I wanted to finish with a few slides to again talk about something that is maybe somewhere between the rituximab and the anti-TGF-beta approach as a systemic treatment, a new treatment, because this is testing a drug that is already licensed and available, and a drug that is showing some potential and is still in clinical trials but might be useful in the future. So this is coming away from TGF-beta and think about another protein that we think is important in scleroderma called IL-6. And IL-6 was known to be an important protein in inflammation, but it wasn't known how important it might be in fibrosis like scleroderma. But again, like rituximab, it's a drug that is available and licensed for other diseases, especially for arthritis. So a few years ago now, again, based on our research work in our patients in the clinic, we saw that there were some patients that were doing very badly with standard treatments, and we noticed that these patients all had evidence of high levels of IL-6 in their blood. You can see here, these were the patients that were doing badly. And we knew they were doing badly because when we looked back, we found that the IL-6 levels early in their disease were identifying how bad they were going to be later on, despite treatment. And we knew that IL-6 was in the skin and the internal organs in appropriate places. So we thought that it might be interesting to block IL-6, and we discussed this with our colleagues, with our scientists, and with the company that makes the drug that blocks IL-6. And in the end, everyone was very interested this was something worth doing, and we were delighted because in the end, the company decided to do a large clinical trial to see if that would be helpful. We'd also seen that IL-6 might be a predictor of bad lung fibrosis in scleroderma, and so we were very excited to sort of be part of this study. And in fact, Professor Van Laa, one of the other speakers, was again very much involved in this at the early stages and as an investigator in the trial. So this now is work that represents a huge number of people from all around the world, because it ended up being quite a large study. But this is what happened when we did the clinical trial, comparing placebo, so no treatment at all, with the anti-IL-6 antibody. So this is looking at something called the skin score, which is this total assessment of your thickness or the severity of your skin disease in scleroderma, something we knew was bad if you had a high level of IL-6. And what you can see is if you were on the active treatment, the blue line, your skin score improved. But if you were on the placebo in this treatment, then your skin didn't improve. So it was very similar to what we'd seen in our patients some years earlier. I should say that the good thing about a clinical trial is that usually once the trial is over and you've gone through the placebo phase, you get access to the drug. So obviously patients then got IL-6, and in fact we're now analyzing those results. So it does seem to help the skin, but we also, and we were intrigued, we also saw some signal it might also be helpful for the lung, because in this early stage of scleroderma, not in patients that we knew had lung fibrosis, we were interested because we watched the lungs carefully to see if they might worsen. And in fact, we saw this signal that they worsened much more. The lung function got worse if you were on the placebo than if you were on the active treatment with tocilizumab. And so this does suggest, again, that it might not only be helping the skin, but it could be also benefiting the lung in some patients. So what this trial did was really confirm our observation in the clinic that IL-6 levels might be important in scleroderma, and at least in some patients might be something that could be targeted with a treatment. And so we're very pleased because now, on the basis of that first trial, there's a much larger trial ongoing, and it's the sort of trial that, if it's positive, I think will again lead to an approval for tocilizumab as a treatment for scleroderma, and it will be another treatment option. So I'm going to finish there, but just to say that I hope you see that there is hope for systemic treatments, but all of these represent much more targeted therapies, and they may only be relevant for a certain subgroup of patients, and they're certainly not likely to be the whole answer. So I will leave things there. I will thank again our patients, all of the people we work with in the UK and internationally, and the patient associations. And I think we'll probably take questions at the end. Is that right? So thank you very much.
Thank you very much, Chris. And as he said, we'll take questions on treatment after the second talk, because it's very similar. And it's my pleasure to introduce Professor Yap van Laa, who's back in his home country, the Netherlands, after a stint through the UK. I've worked for 15 years with this young man, and I think he's a splendid example of someone who has the precision of the scientist and the empathy of a good physician. Yap has pioneered this study, the Astis trial, which he's principal investigator, and introducing new concepts is quite a difficult thing in the conservative world of medicine, but he managed. Yap.
Thank you very much, Alan, for a very nice introduction. Time flies. We've actually been collaborating for 20 years on this field.
I'm becoming forgetful, yeah.
Alan can only remember the last 50.
It's a great honor to be here to speak for patients. I could speak about this topic for hours, and my wife sometimes wakes me up at night when I'm asleep and mumbling and says, "Stop talking about the stem cell project." So I'm glad I can speak about this for at least 10-15 minutes now, and I've decided to condense it to the essence of the project. And I like, to be honest, I like the logo of this meeting. I don't know whether you've had an opportunity to go and see it, but this is the Monument of Discoveries. And I think it's really appropriate that this meeting is held in Lisbon. And I hope this meeting will lead to new discoveries. I'm going to speak about the stem cell transplant project, which we've been working on for about 20 years now under the initial stewardship of Alan Tyndall. And the first thing I would like to say, there's a lot of hype and hope about this project. And what I'm going to show you is some real-life data. And the real-life data will probably tell you a story which is, I hope, more realistic than what you sometimes read in the newspapers. So stem cell transplantation is a medically complex treatment. It involves multiple steps. It also involves a hospital admission on a ward, a hematology or transplant ward for several weeks. So it's very different than standard treatment with drugs, which are taken on an outpatient basis. It also involves the administration of high-dose chemotherapy and antibodies, and some of these antibodies can have nasty side effects because they're actually isolated from rabbits, for example. That sounds strange. You don't grow ears. But these antibodies have an effect on the immune system. But because they're isolated from other animals, they will trigger a kind of allergic response in a patient, which manifests itself as fever and shivering. And this treatment is then followed by reinfusion of stem cells that have been isolated from the patient before the administration of high-dose chemotherapy. So this is one of my patients. Actually, this was a patient with rheumatoid arthritis, but this just goes to show you that the patient is admitted on a transplant ward and everything that goes with it. So how does it work? And a lot of colleagues always challenge me and say, all right, this sounds like hocus pocus, a magic trick, and now tell me in scientific terms, how does it work? And then I tell them, okay, how does paracetamol work? You know paracetamol when you have a headache? Well, although we use it for decades now, we still don't know how it works exactly. And that's the same problem with this treatment. This treatment involves many drugs. I told you chemotherapy, I told you about the antibodies, I told you about the reinfusion of stem cells. So there are multiple steps involved. And that's why it's very difficult to try to understand how it works. But we think it works a little bit like resetting your computer. When the computer screen turns black, what do? You turn Control-Alt-Delete, and then you hope it works again. And in 90% of cases, it works again. And that's a very simple analogy, and that's the same thing what we do with a stem cell transplant. We ablate the immune system, so we create a clean slate for the immune system, which we think is involved in the disease. And then we allow a new immune system to arise from the stem cells that have been reinfused. What are the potential benefits of a stem cell transplant? With an emphasis on potential, because we can't predict whether it will always work the way we intend it to work. So one of the key things is improvement of skin thickening, improvement of quality of life, stabilization of organ dysfunction, and improved survival prospects. So what are the risks of stem cell transplantation? Well, in all cases, patients will lose hair, and they may also develop nausea because of the chemotherapy, although there are pills and drugs which will be able to lessen these side effects. Infections, bleeding, and fatigue are also known side effects of a stem cell transplant. In some cases, we have seen heart and lung failure, especially in Scleroderma patients, and this is because heart and lung function in Scleroderma patients is, in many cases, not normal. And in some cases, these failures have become fatal. Infertility is an issue, especially in young women. Early menopause can also be an issue in women. And then there is the long-term risk of autoimmune disease and malignancies, which is also difficult to predict. So in fact, the list of risks is longer than the list of potential benefits. So why would you go for a transplant? You know, this doesn't sound too optimistic, does it? Well, first of all, we have to understand that chemotherapy is a blunt instrument, as it cannot distinguish healthy from sick immune cells. So healthy immune cells are also killed as collateral damage of the treatment. So this explains why this treatment involves side effects. We are not that clever yet to avoid the side effects. But the key thing is that we think that a stem cell transplant is a way of, a better way of leading to a remission or a cure than standard chemotherapy with cyclophosphamide. And in fact, the evidence that we have published 2 years ago does point in this direction. So it's a little bit like comparing, hitting, a peg with a little hammer, a baby hammer, which takes time, or hitting it with a big hammer, and this in one hit will, have the intended effect. So we started this Astis trial. I'm sure many of you have heard about this trial, which was completed in 2014 and published then, but which was actually started in 2001. So Denton just highlighted the importance of controlled trials. He also highlighted the importance of long-term observations, because we know that long-term observations are important in diseases like scleroderma. So this is one of the trials with a very long-term observation period, 13 years, one of the longest trials in this field. It was done in 156 patients from across Europe, and in fact, 25 centers participated in this trial from 10 countries. So that was quite a monumental effort. But I think it was worth the effort, Alan. So patients were randomized by a computer program to either undergo stem cell transplantation or get chemotherapy. So this trial targeted patients from 16 to 65 because we know that transplant in the elderly are risky. We also targeted patients with early disease, so not more than 4 years of disease duration. With diffuse disease, so not patients with limited disease. So in fact, this trial targeted a minority of scleroderma patients. Patients with major organ dysfunction were also excluded because we knew that if we would do a transplant in these patients, they would have a high risk of complications. And we also excluded patients with who had been pre-treated with cyclophosphamide, because we knew that if these patients would be randomized to the control treatment arm, there was a high risk of the patient dropping out or not responding to the control treatment. So this was a highly selected group of patients, and again, a minority of scleroderma patients qualified for this trial. And this is the key result. This result captures 13 years of work, because it shows the event-free survival, which was the primary endpoint of the study, as we say, and it shows the benefit of the transplanted patients versus the one who underwent the control treatment. So remember, the control patients received 12 pulses of cyclophosphamide in a standard dose used across Europe, and the transplant patients received an autologous stem cell transplantation. So fewer patients died in the transplant group, despite the fact that transplant carries a risk of transplant-related mortality of about 10%, which is not insignificant if you're a patient. So despite this risk, the patients who survived the transplant had a much better long-term survival prospect. Not only did they have a better survival prospect, oh, by the way, this is an important finding of the study. We found that patients who had a smoking history did not have the same benefit of a transplant as the patients who had never smoked. So smoking is bad, and I'm sure you all know, but I know it's also difficult to quit smoking if you're a smoker. But the story is harsh in this sense. If you're a smoker, an ex-smoker, you don't have the same benefit from a transplant. And that's because cigarettes are bad. There's a lot of toxic stuff in tobacco. But not only was survival better in the transplant group, also the effects on skin score on the left, MRSS stands for Modified Rodnan Skin Score. This is the parameter that doctors take when you visit them. It's, pinching the skin. And what we saw was on average, an 80% improvement in the transplant group versus 30% in the control group. And also functional ability, as measured with the HAQ questionnaire, was also much better in the transplant group. We saw some benefit on lung function after transplantation, and we did not see a benefit on heart or kidney function. And in fact, we saw a little worsening of kidney function in the transplant group, which we think is because of the toxic effects of the drugs that we use with a transplant. However, the side effect was temporary, so we haven't seen any significant kidney problems after stem cell transplantation. So to sum up, this study and pilot studies that were done before shows that autologous stem cell transplantation is feasible, it can be effective, but it's not a cure for all. I tell my patients that there is about a 50% of long-term remission after stem cell transplantation, which means that the other 50% don't have a long-term remission. But we should also remember that other treatments in severe early disease are less effective. For example, we know that pulse therapy cyclophosphamide, as the data have shown, are not as effective as a stem cell transplantation. I think the decision to go for stem cell transplantation is a very personal one. It depends on the preference of a doctor, on the experience of the doctor, and on the preference of a patient. If a patient doesn't want to take any risk, then stem cell transplantation is not for you, because there is a theoretical risk of transplant-related mortality, especially in smokers. But I think the data clearly shows that stem cell transplantation should be considered for patients with poor prognosis, early diffuse cutaneous systemic sclerosis. So again, should I opt for stem cell transplantation? There is no data other than the smoking data, which will help the doctor or the patient decide, because we can't predict the future. You know, we are working a lot on skin biopsies, blood tests, to help us in our clinical decision making, but the truth is that these are unreliable indicators of future prognosis. So still experience, you know, of the doctor to see whether a given patient qualifies for a stem cell transplantation. The other important thing I would like to stress is that stem cell transplantation is not done by a single doctor. It's a teamwork. It's actually a large team which is involved in the multiple steps of the treatment. And also nurses are involved. And the result of the stem cell transplant is to some extent also dependent on the experience of the team and the hospital. So your nearby hospital may not have the right experience to do it. They may not even be a transplant center. So this is usually done in academic centers. And in Holland, for example, this is done in 4 academic centers with expertise both in the management of difficult scleroderma and in stem cell transplantation. Also, it's not unimportant to emphasize that this is an expensive treatment. It costs about 50,000 euros. So this is not routinely reimbursed everywhere. In Holland, this is reimbursed by insurance companies. In England, it can be done on an individual basis. I know of some other European countries, but I also know of countries where this is not readily available. And these are all the people who were involved in the stem cell transplant trial. Of course, Alan Tyndall, who is one of the co-chairs, and Dominique Faes from Paris. But as you can see, many people from European centers were involved, and these are just the lead investigators. So behind every name is a team of nurses and doctors who were involved in the trial. And if you want to see the faces, these are the faces. Thank you very much.
Thank you. Thank you. Now, both talks are now open for questions. And maybe I could quickly ask the first question. Yap, patients ask me sometimes, I can see the benefits from the transplant, and sometimes it's quite spectacular. But is there any way of reducing the risk from the experience you've had of these transplant-related morbidity and mortality? What do you think the future will be?
Right. So I have experience with this in 3 centers now, because I set the trial up when I was still in Leiden. I then moved to England and had experience in Newcastle, and now back in Utrecht, where we've done 5 transplants in the past year. And the thing that I think is really important is experience and very close monitoring during the transplant procedure. So you need the best doctors at the bed of the patient.
And do you think we'll reduce this 10% with experience?
And I think that we should be able to reduce it if we exclude the high-risk patients, that, you know, like the smokers, for example. This can be really harsh for a patient if a doctor says you're not a good candidate because there may not be a good treatment alternative.
Okay.
So
Thank you, sir.
Can I just add just very briefly that, so when Yap was in the UK, we had the benefit of working closely together, and of course the Astis trial results came out, and we've set up in the UK an agreed pathway now to assess patients who might be eligible. So if the patient might be eligible and the doctor thinks that, then we have a protocol that's very strict in terms of investigation, and so far We're turning down quite a few patients on the basis of finding heart problems that we didn't suspect, for example. But I think our approach to trying to reduce the risk is being really very, very thorough with our investigations before you consider the patient.
Thank you. Yes, question.
I'm not sure if I missed that at the beginning, but I was just wondering what leads a doctor to suppose or suggest to a scleroderma patient to be subject for stem cell transplantation? What peer group of patients? Because I was just a little bit surprised about patients with problems with their hearts and lungs are not appropriate to have this transplantation. So could you maybe explain this to us?
Yeah, this is a difficult topic, I think. And the difficulty is because I think doctors do not always appreciate the aggressiveness of the disease. And so they would start with methotrexate or mycophenolate and then maybe switch to something else. And before it's too late, a patient is too advanced to be eligible for a stem cell transplant. So I think the key thing why I think the Astis trial was a successful trial is because we targeted patients with very early disease, even patients who had not received chemotherapy. And that was already a very difficult sell for colleagues. Would you really offer a patient, with a benign disease? I don't think it's a benign disease in all instances. Would you offer such a patient a high-risk treatment? Well, the fact is that if you apply this treatment early, the risks are actually less. So diffuse scleroderma means stiff, skin thickness of the face, the chest, the legs, the arms, functional disability, shortness of breath. Actually, shortness of breath is already a sign, might be a sign of, advanced disease. So it might be too late already.
Just one question left. Thank you. Yes, please.
Hello. I just want to ask, looking through all the research that's been done, just the titles. I'm not medical, I'm a nurse, but is anyone researching the cause of this disease? And secondly, I'm curious because I'm on hydrochloroquine.
The mic is dead.
Should I start again, or did you get the first bit? I'm on hydrochloroquine, which is an antimicrobial, which definitely improved my condition. But if it's an antimicrobial, would it not suggest that there is an organism of some sort there?
I think there could be a very long answer to that question. It's a great question, but I think we have to give a short answer. And I think the answer is that there's a lot of research going on, and it's fascinating. So what might cause scleroderma? I think from a practical point of view for patients, of course, once you come to the doctor, you already have the disease. But it may help us to understand new treatments. I think that we can certainly increasingly identify things that might have triggered the disease, and we think that it occurs in someone who has a susceptibility, which may be genetic or complex. But I think that there is research going in to try and understand the cause. And one of the things that may be relevant might, for example, be bacteria infections, or even what's called the microbiome, which are the bacteria that live in your own body that we now realize can regulate the immune system. So all of those things are relevant, and it starts to make sense why antibiotics, for example, could help some patients. But none of these things are really proven to any extent in clinical trials.
Thank you. We have to go on in order of the time, and I would like to introduce to you Alice Martin from Switzerland. She is a scleroderma patient with a lot of support of her husband, and she underwent a rare process of lung transplants successfully to continue a full life. And I hope that she is in a good condition to speak to us, and I enjoy to speak to listen to you speak.
I'm not sure, but
You'll be fine. Just get
Good morning. My name is Alice. I'm 54 years old. I was born in Portugal, but now I'm living in Switzerland. Since 2002, I have suffered from a rare autoimmune disease, systemic scleroderma diffuse. In my personal case, it affects my skin tissues, joints, esophagus, with reflux, and my lungs, with a lung disease called fibrosing type NSIP. I also had positive anti-nuclear antibodies, positive SCL antibodies, and positive anticardiopilin antibodies. Today I will speak specifically about my lungs. Like I said before, scleroderma seriously affected my lungs, and because of that, I was taking 6 doses of cyclophosphamide between November 2002 and April 2003. After April 2003, I took azathioprine until May 2007. Since 2007 until now, I have been taking mycophenolate. But each passing year, the infection gradually grew worse. Any strain was unbearable and painful, so much so that I had to leave my job in September 2005. With the evolution of the disease, doctors began to think about and discuss with me the need to perform a pulmonary transplant in Lausanne, in Switzerland. Thus, in November 2011, I was subject to various tests to determine if I could receive a transplant or not. After all these tests on February 13, 2012, I was officially entered on the waiting list for a double pulmonary transplant. In fact, I must admit that this waiting period was the most stressful because we had to be available at any time of the day or the night. Nevertheless, I'm used to say that despite my misfortune, I'm still lucky, because 4 months later, I was called for the transplant. At 7 a.m. on the 1st of June 2012, I went to hospital in Lausanne when coordinators and doctors were waiting for me. The transplant began at 7 p.m. the same day. The days which fall, especially the first month, are confused in my head because of various complications related of bacterial infections, viruses, and pneumothorax problems. This was accompanied by heavy medication, which caused me to sleep most of the time and put me into a state close to medical-induced coma. After a month, I was transferred for the hospital in Geneva, where unfortunately I had to stay another 3 months owing to multiple infections. In the hospital, I was lying on my back all the time due to the drains, and because of that I lost a lot of my muscle mass. I could not walk. For me, the hardest thing was not the pain or the infections, but the fact that I was not independent. During my convalescence, I was dependent on the nurses for everything, going to the bathroom, taking a bath, eating, even cutting my meat. By mid-September, thought I was finally out of the hospital when went home with a walker, a wheelchair, and also electrodes for stimulating my muscles. As a joke, I used to call my walker my Harley Davidson and my wheelchair my Mercedes. At home, I was helped by a nurse who changed my bandage and gave me medicine. A lady also came to housework for 6 months. Although I used the wheelchair until the end of December, in January 2013, I began to recover motricity in my legs despite some muscular weakness, but I could walk again. After 6 months checkup, the doctors told me that for now there was no sign of rejection and everything was gradually returning to the normal. These long months of convalescence now belong to the past. Even though I had these complications, this doesn't mean that it's the norm. For example, after all, everyone is different. For example, there are people who remain only a month in the hospital, while others like me must stay longer. But frankly, if I had to redo this operation again, I would do it because it meant a new life for me. Today seems much easier, although I still have scleroderma, and I will have to take many drugs for the rest of my life. I can also report that for the moment, all the results of the tests of the antibodies are all negatives. Now I can breathe and walk normally. How we talk. I want to change the image.
Which one?
In May 2014, 2 years after the transplant, I did in 2 hours the 10 kilometers walk of the Geneva Marathon with my friends of the Swiss Association of Scleroderma. And every year since 2014, I have participated also for a 5 kilometers marathon walk to raise awareness about organ donation. In conclusion, I want to thank all my doctors and nurses for their professionalism, kindness, and humanity. My husband and my son for their love and perseverance, and all my friends for supporting and encouraging me all the time. And most importantly, I want to thank with all my heart the donor and this family for their gift, their action and generosity that saved my life. Thank you, all of you, for listening.
Thank you, Alice. Thank you. Is it okay when we ask the questions to the ladies after the second lady has spoken? Okay, and then I want to like to introduce Ramona Kanters from the Netherlands. She's a Scleroderma patient who has been bringing up a family and is refusing to live differently because of her disease. She had undergone a transplant in 2012.
Hello, everybody. Thank you for introducing me. For those who didn't get a chance to see me yesterday, my name is Ramona Kanters. I'm 39 years old, happily married, and a mommy of a lovely 11-year-old son and a 7-year-old daughter. Early 2005, 3 months after the birth of my little girl, I was diagnosed with systemic sclerosis. In hindsight, I can now say that I had many symptoms, even before my pregnancy. Puffy finger, joint pains, intense weariness, rhino, to name but a few. Also, the contours of my face changed. My mouth became smaller, and I experienced other changes in my body. Due to complications, my daughter was born by a C-section after 34 weeks. Examinations showed that both my uterus as well the placenta were hardened. Indeed, things could have very wrong. Luckily, all went well, and my daughter is now a thriving little girl. Till that day, I had experienced many fake symptoms. My general doctor did not know what to do with me. After my daughter was born, these symptoms increased rapidly. My health was seriously compromised, and 3 months after giving birth, I was diagnosed with systemic sclerosis. The specialist told me, "We will try to make your remaining time as pleasant as possible." And there I sat with my 3-month-old baby girl on my lap. I swear I could feel the ground shake beneath my feet. What followed was a very uncertain and frankly scary time, with many different examinations. Luckily, I was referred to one of the best academic hospitals in the Netherlands, the Radboud Medical Institute, where I met the best doctor in the world, Madelon Vonk. A team of experts were at that point working on a trial, the Astis trial, with patients like me. I was selected to undergo treatment consisting of 12 chemotherapy sessions. At first, the chemotherapy seemed to work, but unfortunately, this only lasted for a short while. Eventually, there was only one course of treatment left, the stem cell transplant. After many examinations, to make sure my body would be able to handle such severe treatment, there was positive news. We had a green light. I was to undergo chemotherapy again, coupled with a treatment with EPO. This combination would increase the number of stem cells in my body, so it would become easier to harvest them. I was sent home for a period of 4 weeks. And I can tell you, I made the most of those weeks, with my family, my friends, and a big bottle of wine, the simple but more precious things in life. At the end of those 4 weeks, I was called back to the hospital to undergo the second part of the treatment. The extensive chemotherapy, now coupled with ATG, that's a rabbit protein. The ATG would attack my immune system. Within 12 hours, my immune system dropped to less than 0.1, and my body experienced an allergic reaction. My physician had warned me this could happen. But nonetheless, I was startled by the blisters that popped up everywhere and the raging fever that took hold of my body. I can't remember much of that time. Later on, I learned that the frame time in which the ATG is applied is indeed the most risky in the whole course of treatment because of the allergic reaction. After the stem cell transplant, I improved rapidly. I regained my energy and thirst for life. My skin was rich and hard and began to soften up. I even had wrinkles now. And I think I'm the only one of my friends who actually enjoys her wrinkles. After 3 weeks, I was discharged from the hospital and sent home to recover. The period of the stem cell transplantation has been the most difficult period in my life. But until this day, I'm thankful for this opportunity. The systemic sclerosis has been halted. Although I'm not cured, I will have to live with the damage that was done to my body every day. I've learned to live with it. My motto is, even a life with systemic sclerosis can be a beautiful life, but you will have to throw your own party. Thank you.
Thank you, Ramona. Are there any questions for those who want to ask the ladies a little bit? May I start with the first one? You did survive due a special activity that was done to you. Did you see any difference after the big event that you were?
Yes, of course. Before do the operation,
put it in front of you.
Okay. Before the operation, I could not do anything in the house, even to cook or simple things in the house. I could not. And now I walk 1 hour and a half per day, and I do 1 hour fitness, but soft fitness every day, 5 days per week. Right. And I can do all in the house. I am very happy.
You did take on your normal duties at home and do a lot of things to enjoy and keep fit, I understand.
Yes.
Oh, perfectly. Do you have special things you have done, Ramona?
I got my life back. I became the mommy I wanted to be, but I couldn't be it when I was so sick. I couldn't sit on the ground and play with my children. Before the transplant, that was not possible because I could not get up. I founded. I was founder of Stichting Scleroderma in Holland. My goal was to help other patients, to listen to them and to help them. And I'm very happy that it was a success.
Ramona, I didn't hear your story before, but it's interesting. The very first patient who received in the world a transplant for scleroderma was a patient of mine in Basel. She also just had a baby 3 months before.
Okay.
And her aim, when I told her we didn't know what would happen, she said, I just want to see Robert go to school. That's all I want to do.
Yeah.
Robert went to university, age 22 recently. She's formed her own company, a bio company, and she's very well. And she said it was still the worst time in her life during the transplant, but she would do it again if she knew what would happen.
Yeah, it's the same story for me. Absolutely.
Thank you. Are there any questions left in the audience?
Can someone have 2 stem cell transplants?
Yes, it happens in other conditions. This treatment is not new. It's been used for many years for malignant diseases like myelomas and blood diseases. So yes, you can do it twice. It's not been done twice as far as I know in a scleroderma patient. But what we have noticed is something important. Some patients who didn't either do well or didn't stay well, in other words, they were well for maybe a couple of years and then the skin started getting thick again, they responded very well to simple things like methotrexate, which previously had been useless. And we think that the immune system has been sort of knocked down and previously ineffective drugs become effective. So you may not need a second transplant, you may need just simpler but early treatment.
Oh, there's a question. Do we have, yes, thank you, Anne.
Where are the stem cells taken from?
Yeah.
Yeah.
Okay, so then you mobilize them from the blood, but they're not in the blood, they're in the bone marrow, and you have to give the patient certain drugs which then bring them out of the bone marrow into the blood, and then you just do a kind of machine takes the blood and selects them out for you. But you can't just get them from the blood, they've got to be driven out of the bone marrow. A standard technique for many, many years.
I would like to ask the last question because Chris Denton did tell us about new treatments. What would be the effect of the new treatments for the patient with a transplant when that is needed?
Thank you. I mean, I think that these are not either or types of treatments. They're ways of trying to sort of make progress in the disease. And I think that just as Alan said, it's quite possible that there may be a patient who would benefit from a stem cell transplant, and then if aspects of their disease came back, maybe they would then benefit from one of the newer, perhaps more targeted treatments, or it could be the other way around. But I think that the challenge is, we see, I think, with all of these treatments, is trying to work out which is the best treatment for the patient at the particular stage and the way that the disease is affecting them. So I think there has been progress, but clearly there's a lot more to be done.
I would like to thank you all, especially the speakers, for this, I think, quite interesting and very good stories we have heard. And there is now a coffee break until 11:30. So I would like to say to you, enjoy the coffee. But Anne will say something else also.
I want to remind everybody of something that I said yesterday, which is that we're video recording this Congress. So it's an audio-visual film. It'll be a YouTube link on our website, the FESCA website. We're also recording the translations that are being made in the translation cabins there. And your national organization, if one of those are your languages, your national organization is going to apply that audio to the film that we're making. And so that might take a little bit longer for them to organize. But I'd say that our recording of these 2 days' events will be on our website within the month, in any case. I'm looking at our website manager here who's having a little panic. Within the month, you'll be able to access that link. And I see many people are taking notes and trying to get down the names of all the medications. We've arranged the film so that the camera shoots the speaker and the PowerPoint. So you should be able to get all the details you want by zooming in on the PowerPoint. We'll also put links to some of the PowerPoint presentations. We won't have all of them, but some of them will be there. Enjoy your coffee break, and we'll be back in half an hour.